Hello everyone, welcome to this channel. In today's episode, we'll be talking about the NEET PG question paper, which has been the exam has been last week. So basically, you all were showing interest in knowing what are the NEET PG recent trends, from which chapters generally questions come. So I'll be talking about the obstetrics and gynecology part today. Let us not waste any time. Coming to the NEET paper, there were two sessions. One was the morning session and the other one was the evening session. Coming to the morning session, the first question, as you can see, the first question says that the patient has a patient presented to the OPD as a known case of cervical cancer. On further evaluation, there is pelvic side wall involvement and involvement of hydronephrosis. So what is the stage of the cancer? So remember, if you go for cervical cancer staging, so basically stage 1 is when the lesion is confined to the cervix. When the lesion is confined to the cervix, it is stage 1. So stage 1 is lesion is confined to the cervix. Okay. So confined to the cervix means it is in the cervix. Now in the cervix, it can be either stage 1A or stage 1B. Stage 1A, always remember, is microscopic. मतलब जब तक वो दिख नहीं रहा है आँखों में, तो वो माइक्रोस्कोपिक स्टेज 1A होगा. The moment it is visible, the moment the lesion is visible to the eye, then it is CA cervix stage 1B. ठीक है, इतना क्लियर हो गया. अब 1A में बेसिकली इट इज़ नॉट विजिबल. सो हाउ डू यू डायग्नोस? जब आँख से दिख ही नहीं रहा है तो कैसे डायग्नोस हो रहा है? इट इज़ नॉट अ क्लिनिकल डायग्नोसिस, बट इफ़ यू हैव टेकन अ सर्वाइकल बायोप्सी, अगर सर्वाइकल बायोप्सी लिया है तो बायोप्सी में पैथोलॉजिस्ट कैन डायग्नोज इट माइक्रोस्कोपिकली. सो बेसिकली इट विल बी स्टेज 1A1 एंड 1A2, टू पार्ट्स में हम डिवाइड कर सकते हैं बेस्ड अपॉन द बायोप्सी के अंदर व्हाट इज़ द डेप्थ ऑफ इन्वॉल्वमेंट. You all know that epithelium is there, okay, or endothelium. There is a basement membrane. Until the basement membrane is breached, it is called carcinoma in situ. But when it has already breached and it has gone inside, then it is called carcinoma cervix. Okay, so it has already breached. So the depth of the lesion, kitna depth tak involved hai, will give us the microscopic stage 1 or stage 2. So 1A1 is less than equal 3 mm depth, less than equal 3 mm depth तक involved है, then it is stage 1A1. Stage 1A2 is 3 to 5 millimeter depth of the tissue has been involved by the cancer. Okay, so it is stage 1A is microscopic. It all depends on कितना depth तक involved है. ठीक है, if it is less than 3 mm depth, then 1A1, 3 to 5 mm depth is 1A2. When it becomes visible, जब बाहर से दिखने लगता है on the cervix, if the lesion is visible, then it is stage 1B. So of course 1B can also be divided into 1, 2 and 3. 3 parts में divide कर सकते हैं. So 1B1 is less than equal 2 centimeter diameter. अब ये diameter में हम measure करेंगे because it is visible externally. So no need of going to depth. Now the diameter will be seen. So less than equal 2 centimeter diameter, 2 to 4 centimeters diameter is stage 1B2, and more than 4 centimeters diameter is stage 1B3. So this is all about CA cervix stage 1, so confined to the cervix. Coming to stage 2. Stage 2 can again be divided into stage 2A and stage 2B. Stage 2A is upper 2/3 of vagina. Upper 2/3 of vagina. So when vaginal involvement is there, upper 2/3 of vagina involvement from the cervix, then we say it is stage 2A. Stage 2A can be stage 2A1 and 2A2. So 2A1 is less than 4 centimeters involvement and 2A2 is more than 4 centimeters involvement. So of course 2 centimeter नहीं लेंगे क्योंकि already when vagina is involved and cervix is involved, it is but obvious that this is the cervix and this is the vagina. When cervix से आगे चल के vagina भी involve हो गया है, तो of course the lesion will be more than 2 centimeters only in diameter. So ये less than 4 and more than 4 में divide कर रहे हैं. स्टेज 2B इज वेजाइनल म्यूकोजा के साथ साथ पैरामेट्रियम भी इन्वॉल्व हो गया. पैरामेट्रियम इन्वॉल्वमेंट इज ऑलवेज स्टेज 2B. Coming to stage 3. Stage 3 can be stage 3A, stage 3B, stage 3C. Stage 3A is lower 1/3 of vagina. Lower 1/3 of vagina. Till now we were dealing with upper 2/3 of vagina. So lower 1/3 of vagina is stage 3A. Stage 3B is pelvic side walls. Pelvic side walls. What do you mean by pelvic side walls? Pelvic side walls का मतलब है कि pelvic bone तक involve हो गया है. तो when bone has been involved, there is hydronephrosis and hydroureter. Hydronephrosis and hydroureter. So basically all the urinary stasis and urinary problems, RFT deranged, renal function test deranged, they all are in stage 3B. Stage 3C is lymph node involvement. Lymph node involvement can again be divided into 3C1 and 3C2. 3C1 is pelvic lymph node involvement and 3C2 is para-aortic lymph node involvement. Para-aortic lymph node involvement. And stage 4 of course can be divided into 4A and 4B. 4A is bladder and bowel involvement and 4B is distant metastasis. That is very easy. So basically pelvic side wall involvement, which is diagnosed by hydroureter hydronephrosis, is stage 3B and nothing else. So the question which was asked to us in this exam paper was pelvic side wall was involved and there was involvement of hydronephrosis. So the answer will be stage 3B. Okay, answer will be stage 3B. Coming to the second question. A gravida 2 with a previous LSAS underwent cesarean delivery during surgery and there was excessive bleeding and a hysterectomy had to be done. The image of the uterus is shown. What is the probable diagnosis? So probable diagnosis will be patient has, as you can see in this patient, the picture shows that there is the uterus is already sheared off. Previous cesarean scar is already torn. There is scar rupture and you can see that there is placenta which is adhered to the anterior wall of the uterus and the umbilical cord is also visible. So basically it is a picture of placenta accreta. You can see it is a placenta accreta syndrome whereby placenta is not detached and because of which hysterectomy had to be done. So a very direct question which came this time. Coming to the next question, a 28-year-old gravida 5 para 4 with all 4 girl child presents at 18 weeks and asks for the sex determination on ultrasound. This is her first antenatal visit. What should be done? So what should be done? What can you do? The thing which you can do is, first of all, there are the option says that do ultrasound for gestational age, check for abnormalities, check the sex and tell the mother, or do the ultrasound and gestation age. So see, the patient has come to you at 18 weeks. Patient has come to you at 18 weeks. So 18 weeks is the time when you have to go for anomaly scan. So anomaly scan has to be done for the patient. So अगर इस टाइम पे अगर पेशेंट आएगी 18 वीक्स पे, फर्स्ट टाइम पेशेंट हैज़ प्रेजेंटेड टू यू एट 18 वीक्स पीरियड ऑफ जेस्टेशन. So what you can do is patient का इस time पे what are the things which are due? One is level 2 has to be done for the patient. Then patient's blood investigations has to be done because patient has not come to hospital before. So blood investigations have to be done. So the option says that, see, this will be the option which is most appropriate. Do ultrasound to check for the gestational age. Option C. Check for abnormalities also. You have to check for abnormalities, but don't check the sex of the patient. This is because PCPNDT Act, PCPNDT, that is Preconception and Prenatal Diagnostic Test, PCPNDT Act says that sex determination is banned in India. Sex determination is banned in India. You cannot determine the sex of a child and you cannot disclose it. If you disclose it, then you have both imprisonment plus fine, both has to be given. So that is why you will do the ultrasound. Of course, you cannot say no to the patient. You will also check for all the abnormalities because she has presented to you at 18 weeks period of gestation, but don't check the sex of the child. Coming to question number 4. A 14-year-old girl victim of rape presents to you at 22 weeks period of gestation. Sorry for the technical glitch. So presents to you at 22 weeks period of gestation for abortion. What advice will you give her? So as the MTP Act has been renovated now, MTP Act has already been renovated. So what we can do is, this patient has presented to us at 22 weeks period of gestation. Okay, so at 22 weeks period of gestation, you should remember that now the upper limit of MTP has been increased to 24 weeks. It has been increased to 24 weeks. So till 20 weeks period of gestation, you need only one RMP, registered medical practitioner, whereas from 20 to 24 weeks period of gestation, you require two doctors to be there, two RMPs need to be there, whereas beyond 24 weeks of period of gestation, you need a medical board. A medical board consists of four doctors. One is an obstetrician, and second is your pediatrician, who will tell whether there is substantial anomaly in the fetus or not. Third is the radiologist. Radiologist will do the scan and tell us whether there is fetal problems there or not. And fourth is any independent person whom the chief medical officer of the district tells can be there. Any anonymous person or any doctor, of course, of any specialty can be involved in the medical board. So basically this patient has come to us at 22 weeks period of gestation. So of course MTP can be done, but this will come under POXO Act, that is Protection of Child from Sexual Offence Act. Under the POXO Act and MTP Act, you can do the MTP of that patient, and answer will be answer 2, that is MTP can be done up to 24 weeks of gestation, and 2 registered medical practitioners will be required. So a very easy question. Coming to the fifth question, you are applying a vacuum to deliver a baby in a patient with prolonged second stage. The point at which vacuum is applied. Okay, so what is the point at which vacuum is applied? So basically, vacuum is applied at a point which is called the flexion point. Okay, vacuum is applied at a point which is called the flexion point. So what is flexion point? Flexion point is basically the point at which the vacuum is applied. So if you find, if this is the head, this is the nose, suppose that this is the nose, these are the this thing. So head is facing downwards. Okay, so occiput is always anterior when the baby delivers, and sinciput or the frontal bone is downwards. Frontal bone is downwards. So if you find this is the anterior fontanelle, which is diamond shaped, and the posterior fontanelle, which is actually triangular shaped. Okay, this is the sagittal suture which is in between. So basically the flexion point is a point in the sagittal suture which is 3 centimeters in front of the posterior fontanelle and 6 centimeters behind the anterior fontanelle. Okay, so because the distance between the two fontanelles is basically 9 centimeters, so we divide it into 2:1 ratio, and this point is called the flexion point. It is at this flexion point that the vacuum cup is applied. Now vacuum cup is 6 centimeters in diameter. So when you put the vacuum cup like this, then the edge of the vacuum cup just touches the posterior fontanelle, because the diameter is 6 centimeters and the radius is 3 centimeters. And this is 3 centimeters, edge is 3 centimeters behind the anterior fontanelle. So why did we make a 2:1 ratio? Why didn't we keep 4.5 and 4.5? This is because when we give the traction downwards, then this will lead to flexion of the head. It will lead to flexion of the head. That is why the flexion point is located posteriorly towards the posterior fontanelle rather than anterior fontanelle. So the question which had come is, the point at which vacuum is applied is answer A, 3 centimeters anterior to the posterior fontanelle. So this is the flexion point. A very easy question. Coming to the sixth question, a 23-year-old woman with eclampsia is on maintenance dose of magnesium sulfate. When will you stop the magnesium sulfate? So basically this is an important question. When do we stop magnesium sulfate for a patient? Remember, when we give magnesium sulfate for neuroprotection, or when we give magnesium sulfate for seizure prophylaxis, what are the things that we check? First of all, we check for knee jerk of the patient. Knee jerk of the patient is checked. So all the deep tendon reflexes, okay, are always present. If the basically what happens, you are giving magnesium sulfate, you are giving magnesium. So magnesium will displace all the calcium ions from the body. So all the muscles will relax. So basically muscles will relax. Also the neurons which were activating, because seizures hota hai jab when there is global activation or polarization of all the neurons in the brain. So neuronal activation requires neurotransmitter in the form of calcium. So calcium will also be displaced from the neurotransmitters by the magnesium. So this is how the global this thing contractions will go, and patient will not have any generalized tonic-clonic seizure. This is how magnesium acts. So if there is magnesium toxicity, then in the entire body magnesium will be replacing calcium, and so deep tendon reflexes will be absent, because for deep tendon reflexes muscles have to contract, then only the bones or the joints will move and you will have deep tendon reflexes. So basically we check the quadriceps reflex in the knee joint. So quadriceps muscle will not contract, and so knee joint will not move, and there will be deep tendon reflexes absent at the knee joint. Secondly, you also see for respiratory rate. If the respiratory rate falls to less than 12 per minute, then it says that diaphragmatic palsy has occurred. Diaphragmatic palsy has occurred. So diaphragmatic palsy is very scary, because diaphragm's calcium has been replaced by magnesium. So diaphragm goes into paralysis, and so patient will have respiratory arrest. So if respiratory rate is less than 12, then also we stop magnesium sulfate. Number 3 is you check for the urine output. If the urine output is less than 30 ml per hour, 30 ml per hour, or if it is less than 100 ml in 4 hours, then you say patient is having oliguria, that is less of urine, and that is a condition where you have to stop magnesium sulfate, because this is not because of toxicity, but because of some reason there is renal shutdown and magnesium will not be excreted out of the body. If magnesium is not excreted out of the body through urine, then magnesium toxicity will occur and it will lead to magnesium toxicity. So basically for oliguria, I have already told earlier that 0.5 ml per kg per hour is less than this urine output is said oliguria. So if average weight is taken to be 60 kg of Indian population, then 30 ml per hour is the minimum urine output which a patient should be having. So that is why 30 ml is taken. So the answer says, when will you stop magnesium? So when knee jerk is present, will not be there. Respiratory rate 18 also you will continue. Visual disturbances is not a contraindication, but urine output of 60 ml in 4 hours, that is less than 100 ml, is a contraindication for your magnesium sulfate. So answer will be answer D. Coming to the 7th question. So IUCD can be inserted after delivery. Up to how much time? So always remember that for inserting intrauterine devices after delivery, okay, so for inserting intrauterine devices after delivery, IUCD insertion can be done after delivery. If delivery has occurred, then up to 15 minutes post delivery, up to 15 minutes if you are inserting the intrauterine device, then it is called as post placental insertion of IUCD. Post placental IUCD insertion is when it is inserted in the first 15 minutes. Whereas 15 minutes से लेके next 2 दिन तक, that is 48 hours तक if you are inserting, then it is called postpartum IUCD. Postpartum IUCD, or which is also called as PPIUCD. After 48 hours, we generally don't go for IUCD insertion, because the uterus is involuting and there is high chance of expulsion. Okay, expulsion of the IUCD is very high when it is inserted. So once 48 hours is crossed, then after 6 weeks only, we can go for IUCD insertion, and this is called as interval IUCD insertion. Interval IUCD insertion that can be inserted after 6 weeks. Okay, so from delivery to 15 minutes after delivery, it is post placental IUCD. 15 minutes to 48 hours post delivery, it is postpartum IUCD, and after 6 weeks if you can insert it, then it is called interval IUCD. So after 48 hours you will not insert. So answer A is the correct answer. Coming to the next question, 28-year-old woman whose last delivery was 5 years back presents with secondary amenorrhea for 2 years. So then patient has been given on estrogen and progesterone therapy. Laparoscopy shows the following finding. What is your diagnosis? So basically what we are talking is, we are talking about secondary amenorrhea. So remember, I had already spoken in my classes always that secondary amenorrhea, how do we approach? When a patient has secondary amenorrhea means for more than 6 months patient is not having any menses in a previously menstruating woman, or it can be for 3 cycle length. For 3 cycle length she is not having any menses, then we say patient is having secondary amenorrhea. In secondary amenorrhea, first of all, we give progesterone challenge test. Progesterone challenge test is given. So you give medroxyprogesterone acetate for twice daily for 5 days. Okay. And then you see if patient starts having bleeding, it means कि patient के body के अंदर estrogen था, and now when you have given progesterone, this estrogen has reduced, and once you have stopped the progesterone, both estrogen and progesterone fall down and patient have menses. So if progesterone challenge test say if patient have menses, then you diagnose कि patient was having PCOS or anovulation type of amenorrhea, because of which patient was not having menses. देर वॉज प्रोजेस्ट्रॉन डेफिशिएंसी, प्रोजेस्ट्रॉन हमने बाहर से दे दिया तो पेशेंट को मेंसेस आ गया. बट इफ पेशेंट डज नॉट हैव एनी मेंसेस विद प्रोजेस्ट्रॉन चैलेंज टेस्ट, नेक्स्ट वी गिव E+P challenge test, that is estrogen and progesterone challenge test. Here we give OC pills for 1 month or 21 days we give, and then we stop it. So if patient has bleeding with E+P, estrogen and progesterone, it means patient के body के अंदर estrogen progesterone दोनों की ही कमी थी. So basically there was defect in the ovaries. Basically there was defect in the ovaries, like Turner's syndrome, patient of Turner's syndrome, or premature ovarian failure. Okay, POF. So these patients, their estrogen progesterone both are less in the body, so they will have menses with E+P challenge test. But with estrogen and progesterone also patient is not having any menses, then it means the entire tract is all right, defect is somewhere in the uterus. Uterus में problem है तो uterus कभी bleed नहीं कर रहा है. So basically the most common cause is your Asherman syndrome. Asherman syndrome. In Asherman syndrome there is adhesion in the uterus, and so uterine endometrium is destroyed, so endometrium will never bleed. So basically Asherman syndrome most common cause is your genital tuberculosis. Genital tuberculosis leads to Asherman syndrome as there is destruction of the uterine endometrium. So this patient, as you can see, does not bleed on giving estrogen and progesterone. So it means there is problem inside the uterine cavity. Endometrium में problem है. And laparoscopy is showing this picture whereby you can see miliary tubercles, which you can see over here outside the uterus. So miliary tubercles points towards genital tuberculosis, and genital tuberculosis patients will have Asherman syndrome inside. So your diagnosis will be diagnosis D, which is genital tuberculosis. So a very important question, very common question you get to see in clinical scenario. So not at all a different question, difficult question. Coming to the next scenario, question number 9. Primary amenorrhea with secondary sexual characters present, uterus, ovaries, all are present. What is the karyotype of the patient? So basically patient has uterus, patient has ovaries, so everything is present, and the picture shows that there is a blind vaginal opening. There is a blind vaginal opening. So when there is uterus is also present, okay, you have your ovaries also present, all are present, but the vaginal canal is blind, vagina is obstructed, then there will be cryptomenorrhea. Cryptomenorrhea means patient will have the menses inside, but this will not come out. Cryptomenorrhea. There will be cryptomenorrhea. Cryptomenorrhea, most common causes of cryptomenorrhea will be your this thing, outflow tract obstruction. So it can be an imperforate hymen, or it can be because of transverse vaginal septum. Okay, so these all things can lead to your cryptomenorrhea, where patient will have menses, the blood will get collected leading to hematocolpos, hematometra and hematosalpinx, and then hemoperitoneum when it gets there. Okay, so you have all these findings in there. So this patient, of course, there is no problem with the ovaries and the karyotype will be normal for the patient. So 46XX patient will have cryptomenorrhea. Most of them will present with like this. So answer will be B, 46XX. Coming to question number 10, 34-year-old presents with dysmenorrhea. So dysmenorrhea means patient will have either endometriosis or patient will have adenomyosis. I have already told again and again, endometriosis and adenomyosis are the hallmarks where patient will have pain, because there is bleeding occurring somewhere wherever there is endometrium, and so it will lead to congestion and pain. And laparoscopic finding is showing a large chocolate cyst. You can see a chocolate cyst over there which has ruptured and chocolate material coming out. So obviously it is a very clear diagnosis that it is an endometrioma or endometriosis. Answer A. Coming to question number 11, what would be the mode of delivery in image 1 and 2? Image 1, you can see image 1, wait a minute. In image 1, you can see that the first twin, that is the presenting twin, is cephalic. Whereas in image 2, you can see the first twin, or that is the presenting twin towards the cervix, is breech. Okay, so T1 is cephalic and T1 is breech in this thing. So we all know that in twin pregnancies, if T1 is cephalic, then we go for trial of labor, that is normal vaginal delivery can be done. Whereas if T1 is non-cephalic, be it breech, be it transverse lie or anything non-cephalic, you have to go for cesarean section, because head is a very good dilator, and so vaginal delivery is possible only if T1 is cephalic. So in the first case T1 is cephalic, whereas in the second case T1 is breech. So answer will be C, that is in image 1 we go for vaginal delivery and in image 2 we go for cesarean section. Okay. Coming to question number 12. What type of pelvis is commonly associated with occipito-posterior face to pubis delivery? So you all know there are 4 types of pelvis available. What are the 4 types of principal pelvis available? Number 1 is gynecoid pelvis. Gynecoid pelvis is basically oval pelvis. Okay, it is oval. Anteroposterior and transverse diameters both are equal. So it is gynecoid pelvis. Then you have an android pelvis. Android pelvis is a male kind of pelvis whereby the sacral promontory is projected anteriorly. So the sacral promontory, that is, this is the posterior sacral promontory, this has come anteriorly and it is a heart-shaped pelvis, heart-shaped inlet. It is associated with the worst outcome because head engagement does not occur in android pelvis and there is arrest of labor or non-descent or non-fixation or non-engagement of the head. So android pelvis is associated with poor outcome. The rest 2 types of pelvis, one is anthropoid pelvis. Anthropoid pelvis is anteroposteriorly oval. Anteroposteriorly oval pelvis is called anthropoid pelvis, whereas platypeloid pelvis is the type of pelvis which is transversely oval. Transversely oval pelvis is called platypeloid pelvis. Okay. So anthropoid pelvis, as you can see, it is anteroposteriorly oval. So head will get fixed in face to pubis delivery. So basically the sagittal sutures will be in the anteroposterior diameter, whereas platypeloid, when the head engages with the sagittal suture in transverse diameter. Okay. So this is how transverse arrests occur in platypeloid, or most of the cases there is precipitate labor in platypeloid pelvis. Okay, whereas face to pubis delivery or occipito-posterior or occipito-sacral arrest occurs in anthropoid pelvis. This is very much important. Okay, so the answer will be the B, that is, you can see anteroposteriorly oval pelvis, that is anthropoid pelvis, will lead to occipito-posterior or face to pubis delivery. Coming to question number 13, a very easy question. What classification is shown here? So I had already taught you in pelvic organ prolapse. I'll be again taking lectures on pelvic organ prolapse, whereby this is the POPQ classification which you can see in the question. So you have 9 grid points: A anterior, B anterior, C genital hiatus, perineal body, total vaginal length, A posterior, B posterior, and D. These are the 9 points. So it is the POPQ classification. POPQ classification. Answer B, pelvic organ prolapse. Okay. Every time you get question from POPQ or Shaw's classification, very, very important. Coming to question number 14, a 32-year-old second gravida diagnosed to have deep vein thrombosis at 30 weeks. The drug of choice. What is the drug of choice? So the drug of choice for DVT, always remember, for therapeutic use. For therapeutic use means already there is deep vein thrombosis has already occurred, then you cannot start warfarin. You have to start heparin only for the patients, because heparin has a very short T half. It has a short T half or short life. Okay. So the moment you start heparin, heparin goes to the body and it starts dissolving the clots. Whereas warfarin is a drug which has a very long T half. It has a very long T half. So it takes 72 hours for action to come. 72 hours. So if patient has come with deep vein thrombosis, DVT लेके आ गई patient, and I have started warfarin, so 72 hours बाद 3 days बाद उसका effect आएगा, तो 3 days में तो उसका DVT बढ़ जाएगा. So you cannot give warfarin to a patient who has already developed DVT. Of course you can give for prophylaxis, but in that case you have to be first 72 hours warfarin will not act. So you have to start, if you are starting warfarin, then we generally start heparin and warfarin together. Warfarin and heparin are started together for the first 72 hours. Once after 72 hours warfarin का action आ जाता है, we stop heparin and then we keep on continuing the warfarin for prophylaxis. Okay, so this is how we do. So this patient has already developed DVT at 30 weeks. The drug of choice will be your low molecular weight heparin. So basically we'll give heparin. So whatever is the dose, either we can give unfractionated heparin or we can give low molecular weight heparin. Okay. Question number 15 says second gravida at 8 weeks is diagnosed to have hyperthyroidism. The drug of choice. Remember, the drug of choice in pregnancy is always propylthiouracil. That is answer D. Propylthiouracil is not teratogenic. That is why it is preferred in the first trimester. That is 8 weeks. Okay. But if it is more than 8 weeks, more than first trimester, that is more than 12 weeks, you can go for the other drug which is more efficacious, that is methimazole or carbimazole. Iodine 131 is contraindicated in pregnancy, so there is no chance. Okay. Also remember one thing, when we start propylthiouracil, PTU, when PTU is started, PTU dose is 10 times the dose of methimazole or carbimazole. Methimazole and carbimazole are same drug. So if patient was taking 1 milligram of methimazole, then in pregnancy first trimester we will give 10 times the dose, that is 10 milligram of propylthiouracil is given till the organogenesis period. After that you can switch over to methimazole, because propylthiouracil is less efficacious, number one, and number two, it is very costly drug. It is very costly drug. So that is why most of the patients prefer to take methimazole or carbimazole. Okay. But in pregnancy there is no chance. In first trimester you have to give PTU, propylthiouracil. Next, question number 16. A 45-year-old woman with a history of cervical erosion and spotting for 2 months. What is the next best step? So this patient has cervical erosion, and there is spotting. Okay. So of course, when there is erosion, there is raw area in the cervix and patient is having spotting or bleeding. So there is high chance of HPV infection in this patient. HPV infects through the breach in the membrane, okay, or the endothelium or epithelium. So HPV infection is high, so we always go for HPV screening for in these patients. Also you get a pap smear done for this patient, which will tell ki if there is any dysplastic cells or cancer formation, or low grade lesions or high grade lesions have started forming or not. So pap smear, nowadays the better form of pap smear is LBC, that is liquid based cytology, whereby we send the sample in a liquid medium and then pathologist first centrifuges it and then takes out the cells, and these cells are then used to make the smear and then study the smear or the cells. Okay, so the answer will be answer A, LBC, that is pap smear plus HPV has to be done for this patient. Okay. Question number 17. A primary gravida presents at 37 weeks. She is a known case of heart disease with a prosthetic valve on warfarin. What is the next best step? So I had already told ki if patient is on warfarin, she is already 37 weeks. She is 37 weeks and she is on warfarin. So of course warfarin has to continue, any of the anticoagulant has to continue because she has prosthetic valves. So valves में वरना क्या होगा, valves में clot हो जाएगा and patient will have heart stopping of heart, or the valves will get clotted and will not work properly if you do not give anticoagulant. So anticoagulant has to be given. But if you are giving warfarin and patient goes into labor and patient deliver होने लगती है, there is very high chance of postpartum hemorrhage or PPH. This is because warfarin का effect तो 72 hours तक रहेगा, long half life. So even if you stop taking warfarin for the next 3 days also, its action will be there, and in the next 3 days you cannot wait if a patient has already gone into labor. So that is why we switch over warfarin to heparin at 36 to 37 weeks POG. So now this patient is 37 weeks, she is already on warfarin, so we will switch over to heparin because heparin has a short half-life. Just at the onset of labor, we will stop the heparin, we will let the labor progress, let the patient deliver. Once there is no PPH, that is 12 to 24 hours after delivery, we can restart heparin for this patient. So answer will be answer B, that is switch over to low molecular weight heparin. This is very important. So there are 2 times in pregnancy where we switch warfarin to heparin. First is in the first trimester when the patient when organogenesis is being taking place, and second is just prior to delivery, that is 36 to 37 weeks when patient is expected to deliver in the next 1 week, then we switch over to heparin. Which drug is contraindicated in asthma? Remember, in asthma, the contraindications of drugs is number 1, we don't give many of the drugs. So in PPH, if you see the drugs used in PPH, then carboprost is prostaglandin F2 alpha. This is contraindicated in asthma. Number 2, we do not give ulipristal acetate. Which has many uses. It can be used for medical management of fibroid. It can be used as emergency contraception. So ulipristal acetate is contraindicated in patients of asthma. As well as you have other drugs like labetalol, which is the drug of choice, antihypertensive in pregnancy, is also contraindicated in asthma. So as we can see here, the answer will be B, that is carboprost. Also remember what are the contraindications for the other drugs like methergine, methyl argometrin. Methergine drug has 4 classical contraindications. Number 1, if it is a severe preeclampsia patient. So high blood pressure is a contraindication for methergine. Number 2, if there is RH isoimmunization or RH alloimmunization. Number 3, if patient is having heart disease, any of the heart disease, there is high chance of cardiac ischemia, so we do not give this thing. And twin delivery or multiple pregnancy patients, there also we do not give, methergine is contraindicated. Misoprostol, what is the contraindication for misoprostol? All the previous LSCS patients. So scarred patients, scarred uterus is a contraindication for misoprostol. Whereas oxytocin has no such contraindication except when the urine output is very reduced. Or patient is having AKI, acute kidney injury. In those cases, oxytocin is not given because oxytocin leads to antidiuresis, so water level will increase in the body. If there is AKI, already urine is not forming, and over and above that you are decreasing the urine output with oxytocin. Question number 19, all are members of the medical board of MTP except, this I have already told, radiologist, gynecologist and pediatrician, and a fourth person should also be a doctor. So answer C will be the wrong answer. Legal advisor cannot be the person who is the fourth person. Identify the anomalies seen in this ultrasound. So you can see, if I zoom, you can see a frog eye appearance. These are the two eyes of the frog which you can see. So it will be like this. It is a frog eye appearance. Two eyes are seen like this. Okay, and this is the face of the baby. So basically the eyes are so big eyes. There is no head of the baby. Head is not there. So it is an anencephaly baby. Anencephaly baby. Anencephaly is the baby which is first diagnosed, very first to diagnose, as early as 9 weeks period of gestation you can diagnose it. Okay, so answer will be anencephaly. Identify the prolapse. You can already see the uterus is completely out, so it is a 3rd degree prolapse, grade 3 prolapse with cystocele, that is bladder is also visible. So this is Shaw's classification. Coming to question number 22, 15-year-old girl with wide space nipples, short height. So it is a Turner syndrome, clear cut Turner syndrome, and the karyotype also shows it is 45XO. So Y chromosome is absent, so it is 45XO. Okay. The last question of the morning session is: a woman presents with vaginal discharge. Vaginal smear shows the following. What is the diagnosis? So basically this is the Amsel's criteria which is shown over here, whereby you find a lot of cells. So this is bacterial vaginosis. Amsel's criteria you can study from your own. Okay, sometimes this picture is not so clear. If on zooming the picture, if we find trichomonas, if we find parasites in it, then the answer can be trichomoniasis also. So it is, this question is the only question which is a bit tricky because the picture was not clear. Otherwise it can be between, somewhere between trichomoniasis and bacterial vaginosis. But if the Amsel's criteria they are wanting to tell, then it will be bacterial vaginosis. Otherwise the trichomoniasis will have a lot of parasites which will be seen in the smear. So with this we end the morning session. So I'll end the video here. In the next video we'll be talking about the evening session of questions which had come. So thank you for listening to this video.